Hello.
Yeah, bro.
Okay. Can I have the first photograph of the lady,
Okay.
Henrietta Lacks? Okay, can we start now? It's almost 11 o'clock, and I would like to welcome you to this lecture on Sunday. We have an echo there. Medicine in the tropics. Okay. We had a lecture about cancer in the tropics before, and we stopped at the chemotherapy or the treatment of cancer. But rereading through the cancer registries, cancer data, which is coming from all over the world, I thought of just revising what we have said in the last lecture and then come into the treatment, because great development has been seen in treatment of cancer. Okay, I would like to start with this lady, and this is Henrietta Lacks. Henrietta Lacks. And if you look into her first name, it's H-E and then L-A, Henrietta Lacks line. There is a line, a very famous line now, of cells which are multiplying and giving the scientists and the researchers great opportunity to look into biological research, leading to key discoveries. And only the last COVID-19 has been developed in that line of cells. Okay, what is the story of Henrietta Lacks? Henrietta Lacks is an American, African American. In 1951, she had cancer of the cervix, rather aggressive, and she died with that cancer of the cervix. But she had some cells taken before her death in the lab, and these cells were made to multiply. And they form what we call a line, cell line. And this cell line, if you just have cells of certain types, then you can practice, you can research, you can test a lot of biological substances, you can test immunological, and you can test vaccines. So that is the story of Henrietta Lacks. That is not the end of the story, because these cells were taken out of her without her consent. And now people are talking about how come that this is a lady, black lady, disprivileged. She went to the black hospital, a hospital for blacks only in America, and there is the consent form is not practiced in that hospital. Luckily, her family accepted that these cells will continue. These cells are now continuing the 1951 up to the present time, up to the COVID-19 time, and we do thank, the chance that we have these cells. Okay, that is that is the HELA line, which are now used in research. Okay, we wanted to talk now about cancer. All right, generally, I would like to bring you to the international world and the international registry of cancer. Number one, number two, some of the causes, of cancer in general, and particularly in the tropical area or in the tropical countries. Okay, cancer is what we call NCD, which is non-communicable diseases. And non-communicable diseases, in contrast to the communicable diseases, are not contracted from one person to another. It's a multifactorial, it involves lifestyle, it involves some genetics, it involves environment and low and poverty and socioeconomic disadvantage. So that is a non-communicable diseases. Okay, can we have the picture back? Okay, so uh, it is important to look into NCDs worldwide. Okay, in Africa, up to recently, infection has been dominating the scene, have been dominating the scene in health. But nowadays, with the great improvement on antibiotics, now we have very powerful targeted antibiotics. There is a lot of money being spent in tropical diseases, what we call the exotic or the classical tropical diseases, like onchocerciasis, lymphatic filariasis. There is a lot of money which is being spent, and then these have led to almost elimination of some of these diseases, and we are rest with non-communicable diseases. Nowadays, we can talk about the mortality, the world mortality from disease reaches 71% is due to non-communicable disease. And 70% of this 71% mortality in tropical countries because diabetes, hypertension, renal disease, cardiovascular disease, strokes, these are now common in tropical countries and they don't have all the support of diagnosis and management which is seen in the high income countries. So we are in a challenge in this part of the world, in Africa, because of this highly expensive non-communicable diseases. Okay, because if you take diabetes, for instance, you need a lot of education, you need a lifelong treatment, you need a good follow-up, you need specialized personnel, and so on. So this is more expensive. To me, it's even more expensive than the communicable diseases because this is very complicated because it involves lifestyle and a lot of drugs which are needed for life. Okay, so when we come back to cancer, cancer is one of the major diseases of non-communicable diseases, and I would like to draw your attention to the fact that cancer is being registered as a disease of the world, meaning that the whole world is being interested in cancer. And we learned quite a lot from registries of cancer from different countries. It is very clear now the prevalence of the disease in different parts of the world, be it the advanced or developed versus the non-developed or developing countries, is different. So what are the differences? From these statistics, we can get out some information about what causes cancer. And this is very important. If we know what causes cancer, then we are on the track of good control of cancer diseases. So the registry, we have what an international agency for research on cancer, what is called IARC, which is International Agency for Research on Cancer. And this is an international body which is highly respected, and they have a global cancer observatory. So whatever happens regarding cancer in any part of the world is registered. Okay. Well, it is different from one country to another. It's registering is different. So whatever they get out of the data, crude or irregular, then it is accepted. They try to clean the data, but at the end of the day, they accept the data from these countries. And then they disseminate information about the prevalence of cancer in different parts of the world and the factors which will govern this cancer registry and cancer spread. Okay, so and the Global Cancer Observatory is an interactive web-based platform. So it makes it easy for people to get in, okay, feed information, and the data, the clean data, can in global cancer statistics. All right, what are the data this international agency is interested in? Number one is cancer incidence, and we know now there is different cancer. For instance, CA breast, is all over the world, including tropical countries, but is now being seconded by infection-related cancer, like cancer of cervix, okay, H. pylori cancer, which is stomach, hepatitis B and C, which causes hepatocellular carcinoma. So in tropical countries, infection-related is only second to tobacco-related cancers. Okay, so the indicators which we look for the global or international agency, cancer incidence. So what is the incidence of cancer in different parts? Okay, what is the mortality due to cancer? What is the prevalence? Okay, how is this cancer affected the population? And this we can measure by DALYs, which is disability adjusted life years. Disability, DALYs is disability for the D, adjusted L, life years, adjusted life years. And this is a very important indicator because it doesn't take into account the mortality. All right, you already have the mortality, but here it takes the mortality and the loss of productivity after the cancer. So if you die, then this is bad, but that is one indicator. But if you live with cancer and you cannot go to work, you cannot live your life, and you cannot do whatever you do, this is a disability because of the cancer, and there is a way to adjust it and find how many years you have been disabled because of the cancer. So these are the areas where the data should be collected. Incidence, mortality, prevalence, disability, life years, which is DALYs, and these are the important indicators of the burden, what we call cancer burden in the world. All right, so where do we get the data? From where? One, hospital-based, but this is a bias because people who come to hospital may be the very ill, all right, or the needy who cannot find any place to go. So it's important, it's fine, but it is not as important as accurate. Okay, to tell you how big the scale of the problem in that particular country. So hospital-based is one way of collecting data, and then the other one is histology-based, and this is just you go to consultants of histopathology who are receiving all of them. It has to be all of them receiving specimens from different parts of the country, hospitals and others. All right, and they tell what is the incidence of the cancer from histological point of view. Okay, but the most important assessment of cancer is population-based. population based. And this is very important and it is very accurate. Okay, what is the scale of the problem? We already said that 71% die from NCD. So what is the toll in cancer? Okay, if we take the data, IARC data, in 2020, we reckon that the world saw 20 million new cases. In 2020, 20 million cases. 10 of them died. Okay, so it is that. And today, we can reckon that there is 50 million people living with cancer. All right, so that will give you the scale. What is the incidence? What is the definition of incidence? I know from your public health teaching, you know what is the incidence, and if you say the cancer incidence is defined as the frequency of occurrence, of new cases of cancer in a specific population over a specific period. Say it again. Cancer incidence is defined as the frequency of occurrence of new cases of cancer in a specific population over a specific period. That is the incidence. But the mortality is not just counting deaths. It is the mortality is a product of the incidence and case fatality. So mortality is not just who died, but it is a formula which takes into account the incidence of the cancer in that particular area and the case fatality, how many patients died of cancer, okay, in a given center or a given area. And this will give you the societal burden of cancer, So these are the indicators which I would like you to get into it, because then we are talking international. As far as the world is concerned, the highest incidence is breast cancer. And be it in the developed or underdeveloped, breast cancer is the number one. Okay. However, it is in number 5 as far as mortality is concerned. And while lung cancer, which is the second high up in prevalence and incidence, it is the number 1 killer from cancer. All right. So, what are the top 5 cancers in the world? It's breast, okay, lung, colorectal, prostate. So these are the top, and they vary. They vary in hepatic, okay? They vary. For instance, the hepatic one is highest in Southeast Asia and China, while CA stomach used to be high in Japan, okay? Breast cancer all over. Lungs, unfortunately, tobacco-related is now high in developing countries. All right, but we remain in the tropical area that the higher we go, then we find CA cervix, which is mainly due to human papilloma virus. The stomach, which may be due to H. pylori, which is infection. Okay, the liver is due to hepatitis B and C, and the oral cavity. The oral cavity is a lot of it has to do with tobacco or tumbak, which is used in the oral cavity. So be aware of the fact that these cancers are going for the incidence is different. Okay, why is breast cancer, although number 1, has less mortality? It is easy to think that this is a superficial cancer, on the breast, and the breast is a very sensitive area for women. Okay, so they always try to wash it and feel it, and if the awareness is high with CA breast, so it's early detection, and this is one of the factors which will lead to early treatment and less mortality. Number two is the fact that there is, because of this, it's a superficial cancer, it can be easily targeted by target treatment of cancer, and there is a surgical treatment which is available in many parts of the world. So the sophisticated surgery, but it can help. So this is why one cancer has a higher mortality, while the others are not. Okay, talking about this is we would like to come and talk about the different infections of which will lead to cancer. Okay, because now one of the development and the progress, and we went forward with treatment of cancer is the detection that there are certain infections that can cause certain bacteria, viruses, ailments, which can cause cancer readily. And these are now amenable for treatment. Okay. So before we talk about that, because we will come to the infections, but we have to talk about something which we can control. Okay, very easily. Lifestyle. Tobacco. Tobacco is the plague of the century. It is the plague of the century. It causes 8 million deaths every year. Causes 8 million deaths every year, mainly from cardiovascular diseases, coronary artery diseases, cerebral strokes, hemorrhages, thrombosis, and the peripheral vascular disease, and with hypertension and diabetes, this is a lethal combination which will lead to death and premature death as well. So 8 million per year die out of tobacco-related diseases, mainly cardiovascular disease, but about 2.5 million people die from tobacco-related cancer. So is there any other cancer apart from the lungs that can be caused by tobacco? And the answer is yes. Okay, lung is the number one. But other cancers can be related to tobacco, like pancreas, bladder, okay, stomach, and mouth and oral cavity. The oral cavity could be from smoking, which is cigarettes, or from the local application of the tobacco. Okay, so these are the bad effects: lifestyle, obesity, all right, lack of exercise. All these to lead to the death or cancer, which can be prevented. Okay, if we take the whole list of cancer, we can say 50% of all cancers can be prevented. That is very important information. If we have 50% of the cancer be prevented, then we are on the track. We are on the track. And 50 out of the remaining 50 can be cured, can even be cured, all right, by early detection, by very sophisticated and up-to-date drugs, all right, and by careful surveillance. So the story of cancer also it gives the depression, panic when the patient knows that he has cancer, gives agitation, it can even give suicidal tendency, but it is not. It's not as bad as many people will consider. And why do people consider cancer as a very bad disease? Certainly, it's not a benign disease. It's a killer. It is not being handled well by medical profession. But the bad reputation of cancer has been gained from the latest stage. Okay, so if you see a fungating breast cancer, and the lady sees this fungating breast cancer, then they think if they have a small nodule of the breast, then people will think that these are the one which they have seen. So the bad reputation is from the bad picture of the terminal disease. So this is something which need quite a lot of awareness and health education. Okay, infections. Can we control infections? The answer is yes, either by direct treatment or by vaccination. I think vaccination has really made an impact on the prevalence and the incidence of cancer, particularly those which have the vaccine. Okay, the infections are Helicobacter pylori. Helicobacter pylori, and this is helical. Helicobacter is helical halazoni. Helical pylori from pylora. All right. So this is a bacteria that lives in the stomach lining. But it is asymptomatic. I think almost 100% of all the world population have H. pylori. The incidence and the prevalence is very high. But these are dormant infections. All right. But they do relate to duodenal ulcer development. Okay, that's number one. And very small percentage of adenocarcinoma and non-Hodgkin lymphoma. These are maybe related to H. pylori. And now there are dyspepsia, duodenal ulcer, then H. pylori can be treated easily, by a combination of antibiotics. Antibiotics are very effective. They may develop resistance, but nevertheless, they are effective. Okay. And then human papilloma virus, HPV, human papilloma virus, which is which causes invasive carcinoma, invasive carcinoma of the cervix. Okay, and this is now, it shouldn't happen if we can vaccinate girls. So the vaccination is not at the age of the cancer, but it has to be very early in life of girls. Okay, hepatitis B virus is another hepatocellular carcinoma oncogenic, and it is prevalent in Southeast Asia and China. But there is a vaccination, which is hepatitis B vaccine, which is very effective in controlling hepatitis B virus, in preventing hepatocellular carcinoma and cirrhosis. HCV, which is hepatitis C virus, is responsible of 25% of all liver cancer. Okay, we don't say that viruses are the all causes of cancer, but we are giving some of the causes of cancer. Okay, hepatitis B will be dealt with, and 25% of hepatocellular carcinoma worldwide can be caused by hepatitis C. Okay, hepatitis C, there is no vaccine, but there is an effective treatment for clearing the virus. This is again available, but very expensive. And you remember that in Egypt, Cairo, there is a very high prevalence of hepatitis C virus. We don't know, but there are some theories about that. But there is an effort now, a very big effort, to clear the virus from the population. It's at a very high expense, but it can be done. Okay, EB virus, Epstein-Barr virus. This is the Epstein-Barr. Epstein and Barr are different people. And the virus, as far as cancer is concerned, this is associated with Burkitt's lymphoma. Burkitt's lymphoma and Hodgkin and non-Hodgkin lymphoma. Burkitt's lymphoma is a cancer of children on the mandible or in the side of the face, okay, and it is associated with vitamin B virus in the population living in the malaria belt. So the pathogenesis is dependent on a background of malaria in the endemicity, in the endemic area, and the infection with EB virus. So, and this is being reported by Burkitt's from Uganda, and the belt of malaria goes from that area. This is a childhood lymphoma of mandible and the mandible. Okay, herpes simplex. Herpes simplex, Kaposi sarcoma. This is another virus which can lead to Kaposi sarcoma. And you know that Kaposi sarcoma, the de novo, which is the original one, classical one, it can be called one, herpes. But nowadays we are seeing more of Kaposi sarcoma because of HIV, hepatitis, human immunodeficiency virus. With or without herpes simplex. Okay, is HIV, the virus, is it an oncogenic? I think the evidence is very small that it is the virus itself is an oncogenic. But the virus disturbs the immunity so much that it makes it vulnerable to cancer. Okay, other infections include schistosomiasis. Schistosomiasis hematobium is notorious of causing CA bladder. And because Egypt was the Mecca of bilharzia, the incidence of CA bladder was very, very high. And the urologists in Egypt are almost the best expertise in treating CA bladder, okay, because of the high prevalence and the high incidence of CA bladder. I don't have recent information, but there was big effort in controlling schistosomiasis in Egypt some time ago, about 4 or 5 years ago, and I think the prevalence has gone down. If it's so, then it can lead to drop in the prevalence and the incidence of the cancer of the bladder. Okay, Clonorchis sinensis. Clonorchis sinensis. Clonorchis. Clonorchis sinensis. Sinesis. Clonorchis sinensis, which is the fishworm, okay, which is the food worm, which is eaten in raw food, and it can cause cholangiocarcinoma, okay, and this is again amenable for treatment, so it can be easily treated. Okay, we have to accept the fact that cancer is not a homogeneous, disease, but very heterogeneous, because it ranges from a cancer which has a very good prognosis to a cancer which has a very poor prognosis. Okay, if you look into seminoma, all right, or teratoma of the testicle, then the chance that the patient lives for 10 years after the cancer is 98%. Okay, to live 10 years after the cancer, treatment, it then is 98%. While pancreas is a disease or cancer which is associated with very poor prognosis. The chances for somebody to live for a year after pancreatic cancer is about 12%. So it is a deadly disease. All right. So this is why we have this mixed bag of treatment of diseases which are cannot be taken as one. All right. Okay. Before we come to treatment, I would like to give the symptomatology. Okay. As we said, we have to do an early diagnosis, not even that, but surveillance. We have surveillance for CA, okay, and we have the the pink day. I think there's a pink day for the whole world to awareness on CA breast. To make ladies go and examine themselves, self-examinations. If they have doubt, then they come for a proper palpatory examination by palpation. Okay, and if there is doubt, they go to mammography. All right, so there is a day every year about breast. Okay, increasing the awareness and in many of these surveillance, people have been detected, or ladies have been detected see a breast. Okay, so it is early diagnosis, surveillance, all right, and the early diagnosis is appreciation by the doctor or by the medical profession, not only doctors but even nurses and those who are at the periphery. These are the centers, health centers, or dispensaries of people who should be aware of some of the symptoms of which may indicate cancer, and they be brave enough to refer it to a bigger center or bigger hospital. Okay, I'm not going to be inclusive or comprehensive, but I would just like to give you some symptoms and signs which may indicate, because these are symptoms common to other diseases, but they may indicate the awareness of the doctor to early referral or early diagnosis. So let us start with the lung, which is the killer number one. Is if you have stridor, okay, and stridor is due to obstruction of an airway, either intrinsically or extrinsically, either from inside or by pressure from outside. Okay. Vena cava, superior vena cava, or vena caval obstruction. If you have a superior vena cava obstruction here, then all the blood coming from the head and the face would get congested, you get edema, you get plethora. The face will be red, okay, and the eyes will be red, okay, and you will have dyspnea very, very easily. So this is superior vena cava obstruction, and you will have dilated jugular vein, which is not wavy, it's fixed, just dilatation without a wave. The wave is from the right ventricle or right atrium, which is conducted to the jugular vein to give it the wave. Is the atrial contraction, the ventricular contraction, and the opening of the valve. All this will give the wave. But if you have an obstruction and superior vena cava, there is no communication between the jugular vein and the heart. So it will be just full congested without wave. Okay, so we have a stridor, we have superior vena cava obstruction. This is in the lung, and when we have hemoptysis, we get alarmed. Especially in patients who are more than 40 and who are smokers. Okay, this is an early signal for an urgent chest X-ray to see what's in. Obviously, hemoptysis can occur for infections like tuberculosis, bronchiectasis, pneumonia, thromboembolic phenomena, an infarct of the lungs, all this will give hemoptysis. Okay, but distally you can get cervical nodes, cervical retinopathy, supraclavicular, or cervical. And if you have these, then you are dealing with somebody who has a metastasis. Okay. Cytosis is another feature. Okay, that is lung. What about GI? GI, if you have dysphagia and weight loss, that is something you look into the esophagus, okay, endoscopy. And as we said earlier, now the diagnosis, we have tremendous ability for early diagnosis because endoscopy should be available in many hospitals, secondary care hospitals, and tertiary care hospitals. So it's in 5 minutes you can clearly know if the esophagus is diseased with a mass or not. So if you have dysphagia with weight loss, if you have abdominal pain, upper abdominal pain, and if you have masses somewhere in the upper abdomen or weight loss. Okay, let us talk about weight loss as part of cancer. Okay, weight loss is such a non-specific symptom, okay? It can occur with chronic infections, with abdominal disturbances, even if you have duodenal ulcer or irritable bowel syndrome, then you don't eat well and you lose weight. But it has to be taken with caution. If somebody who is not complaining of any particular or regional illness, he has loss of weight without explanation, then you have to search for a hidden malignancy. We have no problem with external malignancy. If you have lymph nodes, then it is obvious, very clear. Okay, if you have abnormalities in the mouth, masses, then this tells itself very early. If you have breast mass, then this could be easily seen. But what we are really after by hidden or occult hidden cancers, all right? So if you have hematemesis, again, you have to think twice if you have cancer, which could be due to CA stomach, which is common to have hematemesis, all right? But other causes of hematemesis are on the chart, like varices, esophageal varices, duodenal ulcer, thromboembolic phenomena, or coagulation problem. They can all lead to hematemesis. Okay, lower abdomen. The lower abdomen, if you can see a mass or feel a mass. Okay, if you're doing your bathing or showering, then you can feel a mass. Again, weight loss can be important, but we have the advantage of having the stools almost every day. Look at the stools. If there is blood, then this is an alarm. Okay, and as I always say, that blood should not come out of the body or appear in the skin, except from ladies with menses. Okay, if you have nosebleed, if you have oral gum bleed, if you vomit blood, hematemesis, or if you cough blood, then it is something serious which has to be looked into carefully. And if you have blood per rectum, then think about it, okay? One of the commonest causes of blood in the stools is piles, all right, or hemorrhoids. But piles and hemorrhoids, the blood comes either first or last, okay? But if the blood is mixed with stools, especially fresh blood, then it's coming from a lower GI. Okay, and this need to be looked into by a PR, simple PR. You may feel a mass in the rectum or rectosigmoid, or you can have a colonoscopy, it's a short colonoscope or a long colonoscope to deal with to see if there is any masses. So endoscopy can be very helpful in upper GI and lower GI, upper GI and lower GI cancer. Okay, gynecological. The lower, below the umbilicus, if a lady has a mass, then it can be ovarian cyst, which is benign, or ovarian cancer, which has some sinister outcome. If you exclude fibroids, then any mass in lower below the abdomen, apart from pregnancy and fibroids, then it is abnormal. Okay. As far as the breast is concerned, lumps. If you have a lump, small or big, then this has to be referred early and looked into very carefully. Okay, nipple changes or discharge from the nipple, especially if it is blood, then one has to consider referral. All right. The skin changes, very important. And if skin changes in any lady above 50, then this is an early indication for referral. Okay, postmenopausal bleeding. Postmenopausal bleeding is another worry about treatment, about cancer in endometrium, in the endometrium. Okay, so be aware of some symptoms which can refer to cancer inside. CA cervix can present with a lot of symptoms, and some people who walked, in Tanzania and in Rwanda, they see quite a lot of CA cervix, which can present with a lot of symptoms like discharge, blood discharge, and all the rest of the presentation. Okay, I have about 12 minutes, and I would like to touch on the drugs. I know this is a specialized area, and not all doctors are not as allowed, but they don't like to get into the treatment of cancer, because one is highly specialized. Number two, it's now very, very, very specific drugs. All right. And the tailoring of the drug is extremely important. But for any general physician who sees patients with cancer and who may follow up patients after treatment should have a very sound knowledge about chemotherapy. Okay, and even irradiation. Okay, what are the developments in the last, say, 20 years as far as treatment of cancer is concerned? We are talking about cure. And this was not possible, 50 years ago, because A, of early detection, 2, of good surgery, what we have, oncology surgery, and oncology gynecology, okay? So we have surgeons who are just specialized in tumors and cancer, okay? Both in the body and in the gynecology. So we are getting more and more specialized in the treatment. Chemotherapy is a general term. If you are using chemotherapy, you are just saying that I'm using a chemical to treat a disease. So that's chemotherapy. And we talk about chemoprophylaxis. Chemoprophylaxis, which is giving antibiotics to prevent infection, not to treat infection, to prevent infection. Like if you are opening up the colon, okay, and where there is infection, if you are taking part of the colon out, all right, and you fear of infection after the surgery, you give antibiotics just before the surgery and then for a day or two after the surgery. And this is what we call chemoprophylaxis. And you remember the classical one is chemoprophylaxis when you want to treat a tooth, all right, extract a tooth in a patient who have valvular disease for fear of subacute bacterial endocarditis. That's chemoprophylaxis. Okay? But chemotherapy, more and more, is now restricted to the treatment of cancer. We are using drugs for cancer, which is chemotherapy. Okay, so if I tell you about chemotherapy, so I'm telling you about therapy, which is being used to treat cancer. Okay, what is the development in the drugs? Okay, let us talk about groups of drugs because the names are not all that easy, and I cannot give it to you in a lecture like this. But these are names which are highly specialized. Okay, we have untargeted drugs, and targeted drugs. What is the difference? The difference is the targeted drugs is just hits a molecular level at a molecular level. Okay, the untargeted drugs will kill all the cells indiscriminately. Okay, and targeting a molecule has been used in pharmacology for producing drugs which are highly effective, efficient, with low side effects. Okay, and this happened when we discovered that antihistamines acts on the peripheral, like urticaria, but doesn't act on the stomach till the receptor of histamine in the stomach was discovered, and it was called H2. This is why, like cimetidine is an H2 blocker, very much targeted to the receptor of histamine 2. It doesn't act on histamine 1. And this is what we mean by targeting. You either target a receptor, okay, or target a particular enzyme, all right, just that. And here it's going to be efficient and less side effects, because side effects are obtained by drugs which have an umbrella of action, because they act on, say, in the sympathomimic, but they also act on sympathomimic in the ganglion, all right, and on the periphery, and this will lead to side effects. And this targeting has been very well conceived in cardiology. You have beta blockers, that is a receptor, beta receptor antagonist, and not only beta receptor, but we now have beta 1 and beta 2, okay? Beta 1 in the heart and beta 2 peripheral, and we have alpha receptor. So we used to have drugs, anti-sympathomimic drugs, all right? And you just imagine, this is an anti-sympathomimic which works for sympathomimic secretions in the ganglion and in the periphery and all the rest. But now, apart from a sympathomimic, just targeting beta receptor is an advancement. So this is what we call now targeted drugs. Okay, as far as cancer is concerned, we have the untargeted drugs, which may be used in single or in combination. All right, combination here, the theory about combination is the same theory of combining antibiotics against a bacteria. If you take tuberculosis, we use multiple therapy, like rifampicin, isoniazid, and pyrazinamide, just to, one, increase the efficacy and reduce the resistance and reduce the side effects. Because if you are using multiple therapy which are acting in different areas of the molecule, then you can use a maximum of one, adding to the other, synergistic with the third, without reaching the maximum dose of one particular drug. So if you give three, because they have synergistic effect, you don't need to reach the maximum of one particular drug, because if you reach the maximum, then you go into the side effects. Okay, so we talked about surgery, and we talk about now the adjuvant, ADJUVANT, adjuvant therapy. Adjuvant therapy. Adjuvant meaning like it comes with others, with other things, adjuvant. And this can occur or can happen or is useful when we have, say, surgery. If you have surgery for, say, you took out a cancer, say, from the cecum, and you don't know if you have left some cells, then you can give an adjuvant therapy. It just complete or brushing. CA breast, again, if you take it out and you're not sure about if you left some, you give an adjuvant therapy. All right. And then we have new adjuvant. New adjuvant is being used before surgery to reduce the mass before surgery. So this is new adjuvant. It shrinks the mass, make it amenable for surgery. All right, palliative is obviously symptomatic. This is for symptomatic relief, and this is a very big chapter in the treatment of cancer because people may reach a stage where you cannot even do anything apart from palliation. That's relieve the pain and make life slightly better. Okay, the quality of life. So what are the antibiotics which are non-targeted? Okay, these are alkylating agents, alkyl group, okay, and the alkyl group binds to the DNA and causes death of cells, apoptotic cells, that is death of cells, okay. Alkylating meaning it alkyl group used, it goes to the DNA and then it kills the cell. Okay, drugs like this are like cyclophosphamide, busulfan, which is a treatment for myeloid leukemia, and chlorambucil. Okay, then we have the antimetabolite like methotrexate. And methotrexate is used in cancer and in other diseases like rheumatoid arthritis, systemic lupus erythema, diseases which are immune-mediated antimetabolites, okay, which interferes with the cell metabolism and protein synthesis. Cell metabolism and protein synthesis, like methotrexate, fluuracil. All right, methotrexate is being used for other things apart from cancer. And here, antimetabolite, if you give it, you have to beware that you need folic acid as a supplement. Okay, and then we have antibiotics. Certain antibiotics act like an anti-tumor antibiotics, all right? And these interrupt DNA function. Antibiotics, anti-tumor antibiotics interfere or interrupt DNA. And this is like bleomycin and doxorubicin. Doxorubicin, rubicin, okay, or bleomycin. These are antibiotics, but very specific for tumor. Okay, and then we have vinca alkaloids. Okay, this will prevent cell division, okay, and this is like vincristine and vincristine or vinblastine. Okay, the targeted, as we are very short of the time now, the targeted is the small molecule inhibitors, which is translocation cell membrane, all right? And these drugs, small molecule inhibitors, will end with IB, okay? And then we have antibody targeted therapy, like monoclonal antibody, okay? And the monoclonal antibody will affect the immune system and cell growth, okay? And this can be conjugated with the other chemotherapy, and making it combines with B cells, will combine with the B cells and leading to destruction of the tumor cell. Okay, we have endocrine target, which is like anti-estrogen in prostate cancer. Okay, and this is hormonal, which is associated with the hormonal disbalance, like CA breast is usually hormonal, prostate is usually hormonal, and you can use anti-hormone to adjuvant as an adjuvant therapy to prostate or the endometrium. Okay. Okay, the last one, which I have time for, is radiotherapy. Okay. Just before the radiotherapy, because we'll come to that, side effects. The side effects, the more untargeted is the more with side effects. Obviously, if you think about it, we are targeting the rapidly multiplying cells, Okay. And we do have rapidly multiplying normal cells like the hair, okay, like the bone marrow, okay, like genetic, like the fertilization over and fertilization is sperm, okay. These are rapidly dividing. So this will be targeted by the chemotherapy. Okay, this is why we get hair problem and alopecia after radiotherapy or after chemotherapy. Bone marrow depression or bone marrow suppression, which will give you neutropenia. This is why these patients who are having chemotherapy or radiotherapy are very vulnerable to infection because of the neutropenia. The chemotherapy have attacked the bone marrow. Okay, infertility, the very high chance, if these have been given a course, all right, they will be infertile because of the rapidly growing cells, the fertile cells. Okay, radiotherapy, there is a lot of development now in radiotherapy. 50% of all cases of cancer need to be treated by radiotherapy. Okay, and what is radiotherapy? It's ionizing radiation. It's an ionizing radiation which causes damage to the DNA. Ionizing radiation which causes damage to the DNA. Okay, and so it destroys the malignant cells. All right, the chemotherapy can be given as conventional therapy, and this is conventional externally for the whole area. All right, so definitely is not specific to the tumor, but it covers all the area of suspected tumor. Okay, or it could be targeted like stereotactic radiotherapy. This is targeting a small area of the tumor. Okay, and then brachytherapy is when you produce the probe of the radiotherapy, if it's called the probe, into the prostate or the breast or into a vacuum created by the surgery. So brachytherapy is so targeting an area, particularly small area. And targeting is about reducing side effects, okay? About efficiency. You are giving a small dose of radiation, but targeting directly on the head of the tumor, okay? And then we have the radioisotopes. Radioisotopes is you label a substance, and this substance is normally taken by an organ, okay? So if it is labeled, then it can deliver radiotherapy in that way. And the classical example is tumor of the thyroid, okay? So it is a tumor-seeking radionuclides. It is a tumor-seeking. So if we label iodine, which is normally taken by the thyroid, if we label it with a radioisotope like 131, with a radioisotope 131, then the iodine is normally go and find its thyroid home, okay? So it is delivering not only iodine, but it's delivering radiotherapy. And this is another way of delivering radiotherapy. So in conclusion, we have concluded what we started with early on cancer in the tropics. And we have to indicate that the tropics are now suffering from lack of chemotherapy, because chemotherapy is very expensive, especially the targeted chemotherapy. Number two, the radiotherapy. The radiotherapy. Radiotherapy requires a specialized hospital. It definitely requires a highly specialized hospital. There is a lot of precautions on using radiotherapy machines. Okay, a lot of restriction all over the world. All right, buildings is needing to be radiotherapy proof. Okay, and technicians should be available to give the right dose at the right place. Okay, and machines now are being more and more sophisticated, and these are very expensive machines which many African countries cannot afford. So we are still behind in the treatment of chemotherapy in the third world, in the tropics. But I will end with the fact that 50% of cancers can be prevented. The remaining 50%, 50% of them can be cured, and palliative therapy can be organized. Okay, so Arwa is telling us about this Truzu. Okay, Truzu is. Can we have it? The picture. Yeah, these are from the Oxford manual, Oxford books, and this is Armand Truzu, who lived in 1801, 1867. And Truzu, we have a Truzu sign, okay? He is the one who described some thromboembolic phenomena of the lungs, okay, thromboembolic, and he is the one who described the carpal tunnel spasm. That is to say, if you apply the cuff of the blood pressure over the systolic level for 2 to 3 minutes, if you are hypocalcemic, then you get tetany, or you get bending of the hand forward, okay, at the wrist. This is what we call tetany. And so he described that. And Chivostock is another one who described if you hit on the facial nerve here as it exits from the brain or exits from the skull, then if you do that and you're hypocalcemic, then you get twitches. Okay. Why I'm bringing this truth is what he described, very well, died with that disease, thromboembolic phenomena in the lungs. Okay. With that, I would like to conclude, and thank you very much for being with me. I'm sorry that it is 10 minutes over time, but it has been worth it, because we're dealing with a very important disease which is seeing a lot of changes in the epidemiology and in the treatment. Thank you very much indeed, and thank for Arwa for putting this together.